some of the studies we want to do, we need to reach large numbers of people. Sometimes it's because the study is large, but often it's because we're trying to study a very specific subset of disease. So cardiomyopathy is very heterogeneous. If we take dilated cardiomyopathy, for example, it's not really one condition. There's Titin cardiomyopathy, DSB cardiomyopathy, Lamin cardiomyopathy. And even within each of those, every family has a different genetic variant driving it.
Even when we're talking about the same gene, the same mutation, there are other factors at play, and they might be environmental factors like blood pressure or lifestyle, or they might be additional genetic factors, each of which are really small, but when they all act together in concert, they modify the way the disease affects someone. So it's not one disease, it's a great many, and that's a huge complexity that just isn't captured by small data sets or small studies. And that's why we need a really large cohort, and to include people from across all of the UK and even internationally.
We've got a rapidly developing genomic toolkit available to us. So our ability to engineer, edit, correct problems with the genome is moving really fast. So we can introduce new genes, we can edit the genes that are there, we can turn off faulty genes. But that does mean that therapies are very specific to one genetic cause of disease. And so that requires that we reach exactly the right people for a particular study.
Having something like the Heart Hive, where we can store a bit of information that patients give us about their genetic cause, means that we can have access to a group of patients who might be interested in taking part in clinical trials and other treatment options that become available in the coming years, and that could really push forward research and new treatments, and that's exciting.